At the 2017 American Society of Clinical Oncology meeting, we sought out specialists who care for patients with various types of cancer, and we posed the same hypothetical situation to each one of them. When you return home from the meeting, if you were invited to speak to a group of your peers, but you could discuss only one presentation, which presentation would you pick and why?
I think from this ASCO meeting, the most impressive presentation to me was a LION study, which is lymphadenectomy in ovarian neoplasms. And what the study looked at was systemic lymph node dissection versus no dissection at all. And we had always believed that removing lymph nodes, whether they were normal or not, actually patients derive benefit from it. And this study actually negated that concept. Patients had equal progressive-free and overall survival, but what was really striking was that patients actually had more complications and actually a higher mortality when lymph nodes were removed without any benefit. And this is really going to change clinical practice. So I think that we can take better care of our patients from a clinical standpoint without compromising any oncologic outcome.
So the most interesting thing for me at ASCO is the intersection of immuno-oncology and solid tumors. There is an increasing understanding that there are hot solid tumors where the T cells are infiltrating and immunotherapy has a chance to help people respond. And then there are cold tumors where the T cells really aren't attacking the cancer at all, and we put these brakes on like the PD-1 checkpoint inhibitors and they don't work. I think the most exciting thing for me is we're starting to get hints that if we can rev up the T cell population to go after the cancer and then combine that with some of the checkpoint inhibitors, we're starting to see some responses, some really interesting responses in different kinds of cold tumors. So it reminds me of a year or two ago, or even 5 years ago, when immuno-oncology first started to come out and then the first hints started to happen. We're starting to see the first hints, like our foot's in the door, and the next year or two we're gonna burst that door open. For tumors that historically don't respond now to immunotherapy, we think they actually will someday.
I was struck by the lack of survival advantage in multiple studies using the CDK4/6 inhibitors. When the doubling of median progression-free survival came out from palbociclib in combination with letrozole compared to letrozole, I think that the world got excited about the possibilities that we had a quote-unquote Herceptin for ER-positive disease. But the lack of survival advantage makes us pause about, we've seen this before, drugs that increase progression-free survival but don't have a survival advantage. In fact, bevacizumab was one drug such as this. So there were more trials to come, but I think that it gives me pause about how worthwhile these drugs are, really, if they don't have a survival advantage.
As a breast oncology specialist, I would say that one of the most important trials to highlight would be the pembrolizumab monotherapy study that was presented at the oral abstract session. Although the results were not as encouraging as we would have expected in triple-negative breast cancer, I think this study importantly highlights the need to further select, to improve our selection strategies for patients who can benefit from targeted therapies, particularly in triple-negative breast cancer. So identifying new biomarkers and being able to select patients in this disease subtype who have this poor prognostic triple-negative breast cancer and try to improve their outcomes is an unmet need. And this trial highlights how there's so much more work to be done in this area, and that we need to improve significantly our preclinical data, our preclinical work to try to identify these patients who can benefit and improve also the drugs that we have for this patient population.
One of the most exciting areas is a new methodology of treating patients called CAR T cells. And there are many different kinds of CAR T cells, but it is a new cellular therapy for patients with cancer. And even when patients have become resistant and refractory to other kinds of therapy, for example, in leukemia or myeloma or lymphoma, patients can have remarkable responses to these CAR T cells in which a patient's own cells are taken out, they're modified in the laboratory, and they're re-injected to the patient. So a patient's getting their own cells. Remarkably, these cells produce very high remission rates. They not only do that, but even if you get only a small remission, without getting any further chemotherapy, without getting any further cells, those cells already re-injected can continue to work, and small remissions become bigger and bigger and bigger. The survival rates are very high on this type of therapy. We're doing this therapy at City of Hope, but it's also being used throughout the country. And so all practices, all institutions have to become ready for this cellular therapy of cancer.
The one presentation standing out at ASCO, it was the presentation on how we treat patients with brain metastases without use of radiation or surgery, which could be debilitating, and that was the results from the trial Checkmate 204, presented by Dr. Hussein Taubi, showing that with combination of two immune checkpoint modulators, two immunotherapies, one ipilimumab, the second nivolumab, 46% of patients had a response shrinkage of their tumors in the brain, and more importantly, 19% of those patients had a complete disappearance, complete response to their cancers with drugs, not radiation or surgery. This was a presentation which can lead to potential practice changes, and ties well with what we know about the need of patients with brain metastases to get new and better active treatments and other treatment options. The surgery and radiation have suboptimal effects, and if I may, I would actually say that there was another presentation with the same combination from Australian group which completely corroborated these findings. So we now have two independent presentations, two independent trials showing that you can use immunotherapy to treat cancer which already spread into the brain.
I think the most interesting part, of course, in oncology today is immunotherapy. We look at oncology in two ways: targeted drug therapy with personalized medicine, looking at genes and trying to find drugs that may block these. And of course, the area that everybody's talking about is immunotherapy, and the idea is, can you activate immunity to kill cancer? The basis, of course, is trying to figure out how to activate the T cell, the cell that will fight cancer when turned on. We started this work in melanoma years ago, and now we're trying to find out how to do the same thing in other cancers. And we've been quite successful in the last year or two finding new immunotherapies for a vast number of diseases: gastric cancer, ovarian cancer, some types of colon cancer, and microcell instability. When it comes to sarcoma, we've had many disappointments. There are new opportunities coming up, new drug targets, new immunotherapy targets. So I think we're just beginning to scratch the surface. For patients with sarcoma, I guess the take-home message is there's hope, and we have to live in a world of hope. And I think as we move forward, we'll find not just how to combine two drugs, but how to combine the very best drugs for immunotherapy, how to move this field really far forward and make true cures in the field of sarcoma therapy. So that's Sarcoma 2017 at ASCO. I think the hope is in immunotherapy. The other therapy, of course, is targeted drug therapy, and there was some advances here too, but immunotherapy is a way forward. And I'm hoping we'll see more of this to come, and wait to next year, and we'll hopefully hear more in the coming months.
Results from randomized clinical trials have shown that addition of trastuzumab and pertuzumab to chemotherapy improves the pathologic complete response rates in patients with early stage HER2-positive breast cancer. This year at ASCO, we've seen results from two randomized trials using a trastuzumab biosimilar, two different biosimilars, one called CTP6 and one called SB3. Both of them compare randomized patients to the trastuzumab biosimilar with chemotherapy versus the original trastuzumab with chemotherapy, and basically showed the safety, efficacy, and pharmacokinetics are very similar between the two compounds, the original and the biosimilar. None of them are approved by the FDA yet, but in the pathway for regulatory approval, I think these randomized trials are very important to show and give us more confidence that these trastuzumab biosimilars will be as effective as the originals in the future.
The most interesting abstract at this year's ASCO meeting has been the plenary paper on the use of adjuvant chemotherapy in patients with stage 3 colon and rectal cancers. This historically has been sort of the easiest discussion I can have with my patients, which is you have node-positive colon cancer that was totally resected, and you need 6 months of FOLFOX chemotherapy. And that's been the standard now for over a decade and a half. What this study was looking at, and a very worthwhile objective, is do we really need full 6 months of chemotherapy, or can we shorten that to 3 months? Unfortunately, to answer that question, we needed a lot of patients. The sample size had to be huge. And so instead of doing a traditional phase 3 study, they did sort of a pooled analysis of multiple phase 3 studies that were conducted relatively concurrently across 12 countries. The other issue with this study was that patients or physicians had the choice of offering Capox versus FOLFOX. Most US patients received FOLFOX. There were a couple countries, especially Scotland, that had a bunch of patients receiving Capox, and so most of the Capox data is driven by that specific portion of this clinical trial. The challenge is that the dose of capecitabine that's used in Europe is higher than what's used in the United States. For reasons that are still not fully clear, American patients can't tolerate capecitabine at those doses. And so, and the other challenge with this trial is that it was not a randomization to Capox versus FOLFOX, it was physician assignment. And so was there a selection bias? Was it driven by just a few institutions? What about the dose of the capecitabine? Certainly tolerance-wise, in the US, Capox is harder to tolerate than FOLFOX is. So that's another sort of controversy that's going to come out of this trial.
The trial that I'm most excited about at ASCO is a phase 1/2 study of AJ221, a inhibitor of IDH2 in AML. This is a phase 1/2 study that examined a large number of patients giving a once-a-day pill to patients with relapsed and refractory AML. The results of this trial were very interesting in that approximately 30% of patients attained a complete remission or a complete remission with incomplete recovery. This therapy was almost always administered as an outpatient and resulted in durable remissions, not only in the patients who responded to therapy with CRs or CRIs, but also in patients who had stable disease, encompassing more than 70% of the patient population. This contrasts with therapy that we've given before to AML patients, including IDH2 mutant individuals, where responses were similar to this, but the therapy required them to receive very toxic chemotherapy, resulting in them being hospitalized for more than a month. This drug is moving forward, hopefully for regulatory approval, and should be hitting our routine practices, hopefully by the end of this year.
In the lymphoma oral abstracts, two of the most interesting study results were the long-term follow-up of the BRIGHT data and the STILL data. Both of these studies presented long-term progression-free survival and overall survival data, comparing the regimens of bendamustine Rituxan to CHOP Rituxan in the upfront therapy of low-grade lymphoma patients. In the BRIGHT study, there is difference for PFS with R-CVP but not R-CHOP. And in the STILL study, there is PFS difference that is significant between patients who receive BR and R-CHOP. Possibly the difference is that in the BRIGHT study, more patients receive maintenance rituximab. And so the maintenance rituximab may obviate the PFS difference that the BR confers over the R-CHOP. But this is going to be a research question going forward. I think it is very clear that in both of these studies, the regimen of BR met and exceeded its non-inferiority margin, and that going forward for low-grade lymphoma patients, BR as an induction regimen should be considered standard of care.